Hey, what's happening out there in internet land? Let's get started. It's a terrific Thursday. We are logging into you live in the Semo building, 3 stories above our headquarters of UCLA Cannabis Research Initiative. My name, for those of you out in the audience who may not remember or forgotten, is Dr. Timothy Fong. I'm part of the steering committee of our UCLA Cannabis Research Initiative, along with our fearless leader, Dr. Ziva Cooper, who is internationally away today, right? As well as Dr. Chris Evans. This is our last UCLA Cannabis Grand Rounds for the academic year. We have a couple events for faculty. Next Thursday, same time, 5:21, 12 p.m. up here in the 6th floor will be our monthly UCLA faculty meeting for Cannabis Research Initiative. And then we have our Cannabis Conversations is returning on June the 9th in a virtual format at 5 p.m. where we will be talking about cannabis hyperemesis syndrome. So make sure you take your ginseng before that. But today, this is super exciting. We have Dr. Daniel Rafie.
Hi.
This guy.
Is that my
not yet. That's not their cue. Okay. That's not their cue.
All right. You give me some time.
Look at his title. Clinical instructor and fellow. He's doing a 2-year fellowship with our Steve Tisch BrainSPORT program, understanding the impact of concussions, trauma, brain. We have one of his mentors, Dr. Cho, in the background, screaming and yelling, or she will. Who's Steve Tisch? Do you even know who Steve Tisch is?
Yes, he is the owner of the New York Giants.
Okay.
Yeah.
So it's important to know that.
It is very important. Shout out Steve Tisch.
So with that, there's so much interest in this question. How useful, how impactful is CBD in concussion? We are recording this, so if people miss it, you can watch the show again, or we'll host it on our website. With that, I'm turning it over to Dr. Rafie to enlighten us on CBD use in concussions. Thank you. Take it away.
Thank you. And I don't know how I'm going to match that energy, folks. So, but I'll try my best. So first off, thank you so much for having me. I think this is a really exciting topic, and being able to present to such an amazing group is certainly a pleasure. The use of CBD in concussion, I think this presentation sort of stemmed from a review that we're currently writing at the UCLA BrainSPORT program, which obviously is going to cover the use of CBD in concussion, the potential use of CBD in concussion, and we've identified some processes that occur in the concussive injury that potentially CBD would be able to target. And today, given how many sort of mechanisms of action CBD has, as well as the multi-layered processes that occur in concussion, for the sake of time, I'm really going to focus on one emerging process that occurs in concussion that we're just starting to find out that is actually happening in concussion, and then how CBD might be able to address that process that could even dictate the severity of the concussion. Okay, so let's get started. So nothing to disclose, no conflicts of interest or funding sources. So our objectives are just going to be, let's talk about CBD, certainly a lot of mechanisms of action, right? But I really just want to focus on the ones that will be most applicable to this concussion process that I'm going to be speaking about. We'll then talk about that concussion process and then the therapeutic rationale, and then where that sort of therapeutic rationale has taken us in regards to our current research at the BrainSPORT program. So obviously, if you're talking about CBD, there has to be sort of a mention of the endocannabinoid system. And then, we'll talk about the applicable neuropharmacology that could be within the endocannabinoid system, but then also, could actually be outside of the endocannabinoid system. So let's get started. CBD is a cannabinoid, right? There's 100 plus in the cannabis plant. CBD tends to be the second most common one in the cannabis plant behind THC. THC is the psychoactive cannabinoid, right? Induces the high. CBD is non-psychoactive, right? So you take it, and typically there is no sort of altered mentation or high associated with that. This is the endocannabinoid system, and we are not going to talk about it in this granular detail because we'll be here for such an extended period of time. You guys will kick me out. But this is just to illustrate that sort of interwoven nature of the whole endocannabinoid system, right? But nonetheless, we'll keep it pretty simple the endocannabinoid system made up of receptors, ligands, right? Receptors generally CB1 receptor, CB2 receptor, CB2, the CB receptors, CBD doesn't, it's felt that it's not clinically meaningful, its interaction with the cannabinoid receptors. But nonetheless, I do want to mention, talk about the CB1 receptor. It's located generally presynaptically. Its activation decreases neurotransmitter release through the inhibition of voltage-gated calcium channels. And the ligands of these receptors are anandamide AEA, right, which is a partial agonist at these receptors, and then 2AG, which is a full agonist at these receptors. And they bind via this sort of retroactive method where they get released from the postsynaptic terminal, retroactively go back and bind to the CB1 receptor, and then subsequently decrease the neurotransmitter release. And then the enzymes that break down these ligands, FAAH metabolizes AEA, right? MAGL metabolizes 2AG, and then protein transporters are important, right? Particularly FABP fatty acid binding protein, which takes AEA to FAAH for its breakdown. So then let's talk about CBD neuro-pharmacology. Again, this is to illustrate all the different places that CBD can act. Rather, not all of them, but the many that we know about now, right? But we're not going to talk about it in this granular detail. We'll keep it relatively simple. So let's talk about the neuropharmacology within the endocannabinoid system. Okay, so at the cannabinoid receptors, generally is not felt to be physiologically relevant, particularly for the process that I'm going to be talking about. At a CB1 receptor, there's some possible indirect effects, and that indirect effect sometimes is felt to be secondary to elevations in those endocannabinoid ligands, right? So particularly the elevation of AEA. And then how does CBD actually elevate that endocannabinoid ligand and increase the endocannabinoid tone? Initially, it was felt that it did so by the inhibition of FAAH, but that was noted in preclinical studies when they actually took human FABP and human FAAH. This group out at Stony Brook found that actually CBD wasn't inhibiting human FAAH activity. It was actually inhibiting human FABP activity. But nonetheless, the result is the same, which is cannabidiol can enhance AEA levels, which has been shown in this clinical trial of schizophrenics. And that elevation in AEH was actually associated with alleviation of psychotic symptoms relative to another antipsychotic. So, all right, and this is the part that I think is most important, most applicable here. It's what are the actions of CBD outside the endocannabinoid system, right? So ENT1, right? So ENT1 is a transporter that takes up adenosine, right? And why is adenosine so important? Particularly in neuropathology and traumatic brain injury, adenosine is felt to actually be a neuroprotectant. And primarily it does that by decreasing the neuronal excitability, right? And limiting secondary injury secondary to an insult, right? And it also is known to decrease neuroinflammation too. And CBD actually inhibits the uptake of adenosine. So it allows more endogenous adenosine to be available to bind to its respective CNS receptors that are A1, A2, a bunch of different ones. But I really just want to focus on A1, the A1 receptor today, particularly the presynaptic and postsynaptic location of the A1 receptor. Presynaptically, A1's activated by adenosine. It decreases neurotransmitter release by inhibiting those voltage-gated calcium channels, kind of the same way that CB1 does. Postsynaptically, it hyperpolarizes, so it decreases excitability by hyperpolarizing the neuron by enhancing potassium to come into that channel. And this is sort of like a mock-up, zoomed in mock-up from our figure from our review that's coming out. And I did it myself, so please, don't give me too much crap for the simple nature of it. But you can see here, or rather you can see there, you have the inhibition of ENT1, more adenosine is available, binds to A1, A1 inhibits that calcium from coming into the presynaptic terminal. And generally, increasing calcium leads to release of neurotransmitter, particularly glutamate. And then here you have postsynaptic neuron. It encourages that potassium to come into the cell and leads to hyperpolarization, which is basically deactivating that neuronal activity and that depolarization that results. And then the other one is TRP channels, right? So TRP is a channels that are particularly sensitive to cations, especially calcium, and they're known to transmit signals, and particularly they're pretty important, especially in the presynaptic location when it comes to glutamate release, particularly given the co-localization of the TRPV1 channel with V-glut, which is a protein that's been identified on the vesicles of glutamate neurotransmitters. So presynaptically involved with glutamate release, it's also TRPV1 is also located on peptidergic neurons, right? So these are neurons that release CGRP, and CGRP is important because it mediates, it's a nociceptive peptide that mediates the migraine pain pathway, but also contributes significantly to the concussion process, which I'm going to describe a little bit later. So please keep that in mind. CBD has been shown to activate and actually desensitize the TRPV1 channel, right? So a lot of studies are out there that demonstrate just activation of TRPV1. But actually we're finding that there's a specific dose, or not dose, but rather a concentration where CBD activates and desensitizes the channel. Any higher concentration than that will result in strictly activation, right? And that sort of Goldilocks spot I've identified as about 1 micromole. And, you know, given the important nature of TRPV1 to glutamate release and neuronal excitability, it's generally regarded as a primary anti-epileptic medication or mechanism of CBD. And this is sort of that schematic, again, zoomed in. CBD inhibits that presynaptic TRPV1 channel, which decreases the calcium inflow into the cell, decreasing presynaptic calcium and decreasing the release of glutamate. Are you guys starting to catch on with a theme here by any chance in regards to presynaptically what's going on? And the peptidergic, right? We know that TRPV1 activation results in calcium inflow into that peptidergic neuron and the subsequent release of CGRP, right? CBD activates, desensitizes TRPV1, which could then potentially lead to the decrease in CGRP release, right? And these are sort of the some charts and some studies that were done demonstrating that desensitization process. You know, on that left side in 2020, they did, you know, they found that CBD and in vitro dorsal root ganglia neurons was releasing, or rather it was the percent response of those neurons secondary to CBD, you know, was right about the 1 micromole is when we began to see the most significant actual decrease in that CGRP release. And then here on the right side, you can see, you know, with subsequent pulses of CBD administration, there's a significant decrease in the actual current density across that TRPV1 channel. So then the GPR55 receptor, right? Again, glutamate co-localization, its activation results in intracellular increase of calcium. It increases neurotransmitter release too, right? CBD is an antagonist at this receptor. Thus, it's actually been shown that through this mechanism, it decreases glutamate release. And this was actually translated with decreased miniature excitatory postsynaptic currents, which is actually a measure of the postsynaptic excitability, right? And that's what you can see here, right? Blocking that GPR55, which will again decrease the intracellular calcium, presynaptic intracellular calcium level. All right, we're through it. Let's get down to concussion pathophysiology and therapeutic rationale. So what's a concussion? It's a force that's transmitted via a blow to the head. It causes a rapid onset of some brief neurological dysfunction that eventually resolves spontaneously. It's a functional disturbance, meaning there's no structural injury to the actual brain itself, right? If you do a CAT scan and MRI, you're not going to see anything on it. And it doesn't necessarily have to involve loss of consciousness, but it gives you these typical symptoms of headache, light sensitivity, sound sensitivity, brain fog, right? Dizziness. It's a bunch of these non-specific symptoms, but what causes these symptoms is this, right? So this is the acute pathophysiology of concussion as developed by Dr. Havda and Dr. Giza at our program. And so initially, right after the injury, you have loss of ionic regulation, and potassium rushes out of the cell. Calcium comes into the cell. Glutamate, there's just a massive release of glutamate, right? And eventually that recovers, right? But nonetheless, this sort of initial ionic dysregulation ends up leading to potentially all these other downstream effects, right? Axonal injury, plasticity dysfunction, inflammation, things that, we're not entirely certain that they, resolve within, a month time period. A lot of people come in with persistent concussion symptoms at months after their injury, right? This could be playing a role in that state. So one really, really important thing that's been coming out relative to concussion is the presence of this process called cortical spreading depolarization. Okay, and what it is, it's basically a slow propagating depolarizing wave that spreads, throughout a large area in the brain, right? And it's tightly associated with neuronal excitability. And it's seen in moderate to severe TBI, right? And in moderate to severe TBI, it's actually associated with a worse outcome, right? So we know that it's not good, at least in the context of moderate to severe TBI, to be having cortical spreading depolarization events, right? It's known to be the sort of the culprit in migraine aura, and then it's also present in epilepsy, right? So how does cortical spreading depolarization start? Like, why does that happen, right? So usually it's regarded as the reason for induction of cortical spreading depolarization is some sort of event that causes a massive spike in potassium above this sort of critical threshold, right? That will then induce, a spreading depolarization event. Now, can you guys think of anything that we recently talked about where you get a spike in initial potassium? Bueller, right? That's what we just talked about, right? That's what happens in concussion. You have that initial spike secondary to membrane injury from axonal shearing. You have that initial spike in potassium, right? And that is a known trigger of cortical spreading depolarization, right? So, and we see it in more severe TBI, so why wouldn't we see it in concussion? And it denotes greater severity and worse outcome in moderate to severe TBI, so why wouldn't that be the case in more mild TBI, right? And this is kind of what it looks like, right? So if you compare this is what happens in a concussion in regards to the ions. This is what happens in a CSD wavefront, meaning there's no injury, right? Like in migraine aura, right? This stuff is just happening. What does the actual ion, what are the ions doing on that CSD wavefront? And as you can tell, you have that spike in potassium, right? And then down low calcium, that's increase in intracellular calcium, right? And then increase in glutamate. So it's almost identical to what's going on actually after an injury and concussion, right? And then interestingly, what's happening in cerebral blood flow in cortical spreading depolarization. So on the left, there's no insult, right? Meaning this is happening in migraine aura. What normally happens in a non-pathological state or a non-insult state will be, you have the spreading depolarization, and then there's hyperemia, which is denoted as increased cerebral blood flow relative to that spreading depolarization wavefront, right? But then when there's an insult, there's potentially completely opposite effects that happens with cerebral blood flow, right? Actually, there's not a vasodilation response, rather there's a vasoconstrictive response during the insult, which can potentially lead to greater ischemia and greater injury to the axons that have been damaged, right? So, well, does it happen or does it not happen in concussion, right? Actually, a group down at University of New Mexico with Dr. Russell Morton proved that in mice that suffer mild traumatic brain injuries, there are spreading depolarizations occurring, and they're associated with post-injury behavior that are typically seen in mice after concussion, right? And then this is sort of his proof of that. That gray box right there, that is when the injury occurs. Typical voltage shift that's seen in spreading depolarization, typical decrease in overall activity that's noted in spreading depolarization, and then eventually the recovery of that neuronal activity. And then, so what's the blood flow doing, right? Is this a state of it being an insult, or is it just like regular cortical spreading depolarization like you would find in migraine aura? Actually, he's finding that during the spreading depolarization, there's a significant decrease in cerebral blood flow in that state, right? Which is really, really important in concussion, right? Which means you're in a state that you need blood flow, right? In order to recover. So, well, so what, right? So, okay, spreading depolarization is present in concussion. Does that matter? Does it not matter? How do we know? So another study in 2019 with Dr. Booley came out, which says it actually denotes concussion injury, right? Meaning they found that if a CSD was present, there was a decreased percentage of functional deficit recovery at 24 and 48 hours versus if there was if CSD was absent, right? And actually histologically, they saw that, you know, in the ipsilateral and contralateral brains of mice that had suffered a TBI with a cortical spreading depolarization event, there was greater apoptotic cells, and there was greater damage and injury to the actual axons and neurons themselves relative to if there was no CSD present. So how can CBD address this, right? So finally, we're getting to a potential solution to this issue with CBD, right? So ionic homeostasis, right? I think that is probably the biggest thing and the biggest issue that happens in concussion and in CSD, right? Like, can CBD actually address this issue? Remember, potassium in CSD, you have a decreased intracellular potassium, right? Because potassium rushes out of the cell. You know, postsynaptic A1 receptor, we know that that increases intracellular calcium, right? What about, I'm sorry, intracellular potassium? What about calcium, right? So we know in CSD, we have increased intracellular calcium, right? That causes this big release of neurotransmitters, and particularly glutamate, right? And versus, you know, CBD, what does it do, right? Via a bunch of different mechanisms, that presynaptic A1, TRPV1, GPR55, it decreases that intracellular calcium burden, and that translates to a decrease in glutamate release and neuroexcitability, right? So from an ionic homeostasis standpoint, you know, I think this can be pretty efficacious. And mind you, these are just really some of the primary mechanisms by which it can do this. There are other mechanisms by which this ionic homeostasis can be, you know, addressed via CBD. And neuronal excitability, right? So inherently, a lot of these mechanisms by which CBD normalizes ionic homeostasis, it'll also improve neuronal excitability. Neuronal excitability is tightly associated, again, with CSD, right? Because you have that massive release of glutamate, right? But also of note, a lot of these different targets that CBD acts on have significant colocalization to glutamate, right? We mentioned GPR55 does, TRPV1 V-glut, right, has significant colocalization to that. We know that postsynaptic A1A receptor, right, which it's where the hyperpolarization occurs, has significant colocalization to NMDA receptors, right? And also CB1 activation has been shown to attenuate CSD, right? Could CBD's increase of AEA promote binding to CB1 and attenuate CSD? Possibly, I think, right? And then remember CGRP, right? CGRP is released with TRPV1 activation and has been shown to contribute to cortical spreading depolarization, right? CBD desensitizes TRPV1, right? Although there's no direct evidence that CBD decreases CGRP, right? Theoretically, it should work, right? It should be able to decrease CGRP. And CGRP antagonism has been shown to inhibit cortical spreading depolarization there. So certainly, theoretically, I think we might have something there. And this is sort of a graph that demonstrates CGRP antagonism, reducing the percent area of actual cortical spreading depolarization occurring. And this is sort of that function of CBD, again, inhibiting TRPV1, which will decrease CGRP release, right? And then decrease CGRP's binding to glutamate receptor, and then promoting cortical spreading depolarization. So this is this whole thing that we just went over, everything put together for you, right? So we don't want to get bogged down in the details here, but it's just to illustrate, CBD's acting in the presynaptic neuron at a bunch of different portions to be able to increase in calcium, right? And then postsynaptically, it's acting at a couple of different places to be able to decrease that depolarization that occurs via hyperpolarization. All right, so what are we doing? So this is all cool. This is all theoretical. Are we actually putting action behind this? And we certainly are. We're currently collaborating with a preclinical pilot study with the University of New Mexico Neuroscience Program. Dr. Russell Morton, whose study I just showed you demonstrating CSD in mice, right? We're working with him to be able to identify whether CBD can actually attenuate CSD with both a pre-treatment of CBD as well as a post-injury treatment. That is pending because apparently New Mexico has some pretty strict regulating laws for CBD. So, but we're currently working past that. And then we also did a retrospective analysis of CBDs in UCLA BrainSPORT TBI cohort. It was about 958 patients. It's not completed right now, but we're collecting all this data. We're trying to find associations. Who's using CBD, who's not, what percentage does it compare to the general population of CBD use, right? Which I've seen a lot of percentages from 10 to 33%, right? We found we collected 228, we found that there was 25 CBD users, right? All were concussion, there were no more severe TBI. We also found that 8 were military, which is very interesting. The symptom severity, meaning the amount of symptom burden that they had after their concussion really varied. So that didn't really have any significant association. And a lot of them had pre-existing headaches and anxiety and stuff like that. Now, we are also currently doing a grant application with the CMCR. And the application will be to investigate the safety, tolerability, and efficacy of CBD in subjects with persistent post-concussion symptoms. It'll be a proposed double-blind, randomized, placebo-controlled trial. It's a 16-week duration. They get 4 weeks of treatment with CBD with either 200 milligrams BID or 400 milligrams BID or placebo. And then we measure their symptom scores, their functionality, their adverse effects, assessments as well on a weekly basis. We're also doing blood draws. Since we're looking at safety and tolerability, we'd like to look at LFTs. And then, again, this is a collaborative endeavor between us and the UCLA Cannabis Research Initiative, and it's really exciting. And we'll let you know if it gets approved or not. So in summary, relatively significant portion of our concussion patients via our preliminary data seem to have a history of CBD use. And this data was gathered via retrospective review, right? Meaning we're really digging in the chart to see if there's any mention of CBD, right? Because right now there's no templated version of do you use CBD or not. Most of the time it's marijuana or not, right? Do you use any drugs or alcohol, and then it's open-ended. But since then we've changed the template to include specifically, are you using CBD or are you not using CBD, or have you ever used CBD? So potentially prospectively, we would be able to get some better data. I do believe that the numbers that we have now are pretty deflated because of that. And we just went over one, I think, reasonable therapeutic potential for the use of CBD in concussion. Also, we didn't talk a lot about it or at all about it, but I think the side effect profile is really good for CBD and creates, it makes it really ripe for actual research. And because of that, I think the time is now for research in looking at CBD specifically in concussion. And I think that, we're kind of doing that via, these grant applications and these chart reviews and whatnot. But at the end of the day, it really wouldn't be, no one would be able to do this if it wasn't for everyone involved at the UCLA BrainSPORT program. So certainly an acknowledgement is necessary for them. Does anyone have any questions?
There's tons of questions, particularly online. I'm going to take a few stabs at a few things. So, do you feel then that CBD would be better as kind of a prevention for people to take it all the time to protect it if they get hit in the head? Or do you think, like, after they get hit in the head, you start firing them right away within the first like hour or 2 hours, that might stall the worsening?
Yeah, I mean, if you ask me, in an ideal world, we would be looking at this as a preventative measure for people that are particularly at risk. But I think that where the research needs to start is where the low-hanging fruit is, I think, which for us is those patients that are coming in that are particularly interested in trying CBD, right? Because they've had their post-concussion symptoms for months to potentially years, right? So certainly, but I do believe that there's a potential benefit of CBD in that context, right? Because, for example, a significant symptom in post-concussion is headache, right? It's the most common symptom post-concussion. And what we've been finding, or something that's been posited, is that actually cortical spreading depolarization contributes significantly to post-concussion headaches, right? You have the sensitization, there's an element of aura associated with it sometimes too. So, I think it could benefit in that context too.
So it's certainly possible that CBD could actually alleviate and relieve post-concussive symptoms, for sure. The next one I always get, I get this 1,000 times, is there's all those other cannabinoids that bind inside. Do you think THC has the same kind of effects as CBD would for concussion? Or do you think, again, when you take whole plant stuff, everyone's always big into this. I'm going to take whole plant, and we don't know what really is binding. Like, so how do you respond to those kind of charges? I
think that, THC certainly has the psychogenic effect, right? Which makes it not ideal for its benefit. And the thing about THC is that its psychogenic effect and its cognitive effects are significant when you're trying to improve someone from post-concussion symptoms, right? Because cognitive symptoms are also significant post-concussion symptom, right? Meaning you don't want to come in, smoke marijuana or here's some THC, you improve their headaches, but then now they're having worsened cognitive symptoms, right? So I think that what CBD provides is sort of potentially an element of improvement that might overlap with THC without the psychogenic and cognitive effects.
Then you can. So I got this football player who suffered concussions, insists that the inhaled flower THC is the only thing that handles his concussion. Told him to go to CBD only, but nowhere near those doses, the 200, 400 milligram. That would have cost him like a fortune to get.
Mm-hmm.
So what are people supposed to use right now before we have those clinical trials? Because anything you buy CBD off the shelf, it's like 5, 20 milligrams CBD. It's not even close to what we use in research.
Yeah, I think, I'm always skeptical of advising on using the supplemental CBD that's going around, because, you don't want to point to someone that isn't third-party tested, right? It might have some other elements, right? I think that's why it's really important to do this research, is because, no other compounds, right? Just isolated CBD. What can CBD do for people? So again, it's really hard to say, really hard to point someone in the right direction in regards to CBD, particularly because it's not regulated.
And someone answers my question was whether you would advise someone not to take CBD right after they had a concussion because of what you were saying with the TRPV1 channels and activation leading to that CGRP release.
Yeah.
So it might require some desensitization after like a long time use of it. So you'd probably say don't go for CBD after the concussion.
Yeah, I mean, honestly, my sense isn't don't use CBD because of the target mechanisms involved in CBD. I would be a big proponent of CBD use right after concussion if it would be only CBD, right? And if there was some sort of research established, right? But right now it's like you're recommending CBD, but you can't trust that it's only going to be CBD, right? And I can't speak for any of the other compounds that are involved in the CBD supplement. Yeah.
We have one online question.
Christina, do you want to handle the online question?
I am.
Appropriate language
Appropriate.
only.
We do have one from Sandra Hawley. What would be the best route of administration to make sure the appropriate concentration gets to the brain and that targets the concussion but not interfere with other brain processes?
Yeah, I think that's an excellent question, Sandra. We're currently doing oral because, that's honestly probably the easiest to get and the easiest to research, right? That's what we're doing in our grant application because we feel it's kind of the easiest to systematically study. But we know that the bioavailability of inhaled is 100%, IV, 100%, versus the oral is about like 6 to 10%. So I agree that's a significant concern. But I think that inhaled, you might be doing damage to your lungs, so I wouldn't recommend that. I wouldn't recommend shooting up CBD, definitely not, right? Particularly because a lot of the other things that I said, it's never good to be shooting anything up. So I think your best bet is probably going to be oral to just, be the most safe. It's certainly better than subcutaneous in terms of it being more bioavailable for any sort of CNS effect.
We have a question for Ina Wagner. Do you assume CBD works also on astrocytes in analogy to A1 receptors that are supporting astrocyte metabolism and respiration?
Yeah, I think that's an excellent question. My presentation today was in a specific process that is heavily dependent on neurons and the synapses of those neurons. In regards to its effect on astrocytes, I certainly think that it can be beneficial, particularly from a neuroinflammatory component. And, those astrocytes, what we've been finding is actually CBD can potentially improve some of the blood-brain barrier permeability that results after neuropathology. And those astrocyte feet really surround the actual blood vessels and, potentially any improvements that could come from A1 binding to those astrocytes could be a potential theoretical reason why CBD might improve the blood-brain barrier permeability.
And we have one question from Igor Spiegelman. Would it be possible to use Epidiolex off-label for the proposed studies?
Oh, what? Epidiolex. Yeah. That's an excellent point, and certainly a channel that I've tried to go through already to be able to use this. It would be ideal, right? It's already established, it's already FDA approved, but doesn't seem like GW Pharmaceuticals or whoever is that manufactures Epidiolex now. I think they underwent some sort of buyout or something, but they're not currently interested in this indication for Epidiolex.
Wasn't there some barrier where you couldn't even prescribe it off-label at some point? I know Epidiolex is very, very expensive.
Yeah.
Number one.
Yeah.
I thought there was some barriers to physicians even writing it off-label.
Yeah.
Joe, do you know that?
I've only ever written it for seizure patients, so I feel like I don't know. I haven't tried to do it for another.
Yeah.
And I don't have very many seizure patients anyway, since it's in my specialty.
Yeah. I'm not aware. Certainly, state to state regulation kind of thing. Again, they're having trouble getting any sort of CBD down at University of New Mexico to just do preclinical studies. So, yeah.
That's interesting.
Yeah.
And what documented either case reports or actual case series are there in the literature right now showing that CBD has helped people with concussions? Is that literature thick at all? Or
no,
pretty thick?
it's extremely thin. I wasn't able to find anything. In my review, there's nothing looking at specifically cannabidiol in the context of concussion or traumatic brain injury. One comes to mind where they did a study looking at cannabis, right? But they looked at, these patients it was for headaches. It wasn't even for concussion. It was cannabis with high THC content versus cannabis with high CBD content, right? And there was significant, I think almost 50% reduction in subjects' headache frequency, but they found that there was no association with the THC or CBD content associated with it.
Which is why your retrospective review coming out would be so important.
Yeah.
Yeah. Some literature on the use of CBD.
Yeah.
Even though it's a retrospective.
Right. I think, the only research that I'm able to come across right now is preclinical, looking at specifically CBD in the context of head injury. And this is some of that research, right? So I'm not going to delve into it. I don't even know if we have time for it. probably, maybe not. But, either way, this study did oral CBD, found that, they simulated mild traumatic brain injury in mice. They found that it prevented the neurological dysfunctions that are typically associated with with concussion, right? So these sort of neuropsychiatric symptoms, anxiety, depression, aggressivity, found that it improved those. They found that it improved allodynia, right, which sometimes is a marker for neuronal sensitization, which tends to happen in, sort of these sensitized, where you're sensitive to light, sensitive to sound, sensitive to activity. That's felt to be secondary to that sensitization. And then they also found that there was decrease in certain neurotransmitters that are typically sort of out of whack after a mild traumatic brain injury, particularly glutamate and GABA. And then also there's this one which demonstrated that CBD actually attenuates a blood-brain barrier permeability after brain injury. This is a more severe brain injury, right? But I think nonetheless, it sort of gives us an idea as to the potential benefits of CBD for just traumatic brain injury in general, right? We know there's blood-brain barrier permeability after concussion, right? Here they even show that there's decreased necrotic neurons, right? We know that neurons are injured after concussion. GFAP, for example, was decreased with CBD-10. And GFAP is actually one of the potential leading candidates for it being a biomarker in the context of concussion, right? So certainly, I think it's pretty significant, these findings, but nonetheless, right, it's preclinical, it's not really very well controlled, but I think it's sort of the signal that we might have something here, right?
That's really interesting. So like, with the folks who come through the BrainSPORT program right now, what are they saying about the patients themselves about CBD? You know what you're going to say, but what are they saying to you?
So anecdotally, anecdotally, a lot of them that haven't tried it are interested in trying it. And then those that have tried it, some of them have had benefit from it. Some of them have not had any benefit from it, right? But it's really tough to make decisions on efficacy off of anecdotal reports, specifically in the context of something that has so many confounding factors, right? Where are you getting your CBD from? Is it third-party tested? Is it not? What else is in it? How much actual CBD is in it, right? You're taking 10 milligrams of CBD, orally, 6% bioavailable. How much CBD actually gets into the brain for that? It's like, I don't know, you do the math, right? It's negligible.
It's so frustrating for us as MDs. We deal with this all the time, and we want something to work right, and we want something to be really thoughtful, but we can't always do that. So I mean, again, and so at parties, do you think, and do you tell people about CBD? Do you tell them, oh yes, this is really a neuroprotector, or do you say this is like a neuro cleaner that'll clean off stuff? I mean, how do you like to describe it?
I describe it as a neuroprotectant. Yeah, but if you want to talk about neuro cleaner, and we can certainly go down a rabbit hole if you want, I'm happy, I can talk about this stuff all day, but there's actually another preclinical study of that they were trying to simulate Alzheimer's disease by injecting beta amyloid protein into mice. And they actually found that CBD decreased the beta amyloid load in these in these mice. And they actually found, I think they also found improvements in their behavior too, relating to that decrease in beta amyloid load. But again, right, when you're talking about dementia, particularly Alzheimer's disease, there's a big issue because there's a lot of drugs that decrease beta amyloid load, right? And none of them have been FDA approved for Alzheimer's disease because there's no clinical translation. Their memory doesn't get better. Their actual symptoms don't get better. Certainly there might be something there in terms of it being a neuro cleaner. We know that beta amyloid is associated with CTE, right? And we feel that also associated sort of this tau protein deposition. Again, that's as much as I can say about it though, in regards to being a neuro cleaner or any sort of context in repetitive head injury.
Christina, anything else from the online space? So is your next few projects on CBD are exactly what in the next year or so?
So we are going to complete this retrospective analysis of sort of the CBD use. We're applying for a grant to the CMCR for this RCT, looking at CBD use in persistent post-concussion symptom patients. And I think that'll pretty much take up the rest of my year.
And that CBD comes from that New Mexico source?
No, that's coming from actually Dr. Ziva Cooper is getting it for us from I think Canopy, right? Yeah.
From her backyard. Don't get that on from Canopy. Right?
Yeah,
A federally government approved source of CBD
Right.
for clinical research. Right.
Yeah.
So, thank you so much.
Yeah.
Well, great. Thank you. This is really great info.
Thank you for having me.
We recorded this. We'll come back and do more. And please give us an update.
We'll do.
Dr. Cho, anything you want to tell us and share with us from the world of neurology and CBD and things like that? Okay. So what is this? These three things here.
Which
the
one?
TISH, BrainSPORT, Brain Injury Research Center, and the Easton Clinic for Brain Health.
Thank God Dr. Che's here, so maybe she can elaborate a little bit. So I don't know, the BrainSPORT program is sort of our program that was established as part of the UCLA neurosurgery, right? Secondary to a donation from Mr. Steve Tisch. The Brain Injury Research Center is sort of a translational program where, we're doing preclinical and clinical research on brain injury. And then Easton Clinic for Brain Health is a program for just overall brain health, not only in, traumatic brain injury and pathology, but also, optimizing, everyone's brain health. Yeah.
That's great. All right. Thanks so much, Paul.
Thank you. Thank you, everyone. Thanks.
Please eat these cookies. They're CBD free.
Then I'm not having them.
Unfortunately.
Do you want me to do anything here?
I can just put in that sleeve.
Actually, do you mind taking a picture of me in front of?
Of course.
Oh, no, we should take a picture for our website. Yeah, make sure, yeah.
Oh, did you?
Yeah.
Also, shameless plug, check out the UCLA BrainSPORT podcast. It's a program, it's a podcast that we set up as part of the BrainSPORT program to talk about brain health. And I'm planning on having an episode on cannabis.
Okay.
And the potential benefits of chronic pain.